Hello, my name is Donghyun Sin from Samsung Medical Center, Seoul, Korea. And today I'd like to present a case of chronic hepatitis B patient with rising serum alpha-fetoprotein level. So this is a 69 years old male with chronic hepatitis B. He has been treated with antiviral therapy since March 2003, and currently he was taking tenofovir. This is his laboratory findings. His blood level is normal serum albumin, bilirubin level, ALT level was within normal range, and his virus level was well suppressed. And you can see his ultrasonographic findings in the right panel. There was no evidence of HCC or solid mass. As he was old-aged man with a chronic hepatitis B infection, he has been receiving regular HCC surveillance using CT or ultrasonography alternatively, along with serum alpha-fetoprotein level, and his serum alpha-fetoprotein level was continuously rising, even though the level was still below the upper normal limit of normal. So this was a summary of HCC surveillance 2.5 years before the index visit. Alpha-fetoprotein level was 1.3, and there was no evidence of HCC. 1.5 years before, his alpha-fetoprotein level was 2.6, and ultrasonography surveillance found no evidence of HCC. And 6 months earlier, from the index visit, his alpha-fetoprotein level was 3.8 nanogram per milliliter, and CT surveillance showed no evidence of HCC. This is a quick summary. The 69 years old non-cirrhotic male with chronic hepatitis B under antiviral therapy, persistently normal ALT, undetectable HBV DNA, and steady rise in serum alpha-fetoprotein within normal range, and no suspicious nodule by imaging studies. So the question for today is, what should we do at the next visit of the patient? Thank you.
Thank you very much for giving me the opportunity to have a presentation at this meeting. I will talk about the use of biomarkers in surveillance for HCC. In my talk, I will present three subjects. First, AFP and other biomarkers. Second, different HCC marker profiles by etiology. And third, the combination of markers. This is worldwide recommendations for HCC surveillance. Main academic societies for hepatology recommended semi-annual surveillance with ultrasonography and AFP as an optional. In contrast, Japanese recommendation includes three markers, the measurements of AFP-L3 and PIVCA2 in addition to AFP. Three tumor markers are routinely available in current clinical practice in Japan: alpha-fetoprotein AFP, lens clinaris agglutinin reactive fraction of AFP, AFP-L3, and protein-induced by vitamin K absence 2, PIVCA2, also termed as des-gamma carboxyprothrombin, DCP. AFP-L3 or DCP elevation is sometimes observed in HCC patients with normal AFP. I will show the case. The patient was a 68-year-old female. She had been infected with HCV and with F3 liver fibrosis, but achieved SVL by direct-acting antivirals on March 2016. C continued regular hospital visit every 6 months after achieving SVL for surveillance of HCC. On September 2020, 4.5 years after SVR, her B-mode plain ultrasonography study at her regular visit detected no evident hepatic nodule. However, the sudden elevation of AFP-L3 was found on the laboratory examination at the same day of ultrasonography. In contrast, AFP and DCP remained in normal range. I immediately planned to conduct dynamic CT at the same day, which revealed the presence of HCC tumor just next to gallbladder. In this case, only AFP-L3 elevation suggested HCC development and triggered cross-sectional study. When I see the changes of AFP and DCP carefully and retrospectively, there were minute increase in these values, but it will be difficult to recognize them as an increase in tumor markers. Usually, we understand this as a normal fluctuation. This case was somewhat similar to the case that Professor Sim presented. His case showed similar change in AFP. C underwent hepatic resection and the diagnosis of HCC was confirmed pathologically. Because the interval of her visit was 6 months, HCC might have progressed if I missed it. AFP-L3 and DCP can sometimes help to detect HCC in patients with absent hepatic nodules on ultrasonography images and normal AFP during surveillance. Next, I talk about the differences in biomarker profiles by etiology, especially focusing on non-viral HCC. The percentage of patients with non-viral HCC is increasing continuously in Japan. This will be the same in other Asian countries, I imagine. This will be partly due to the prevention of new hepatitis viral infection and partly due to the emergence of effective antiviral drugs. In our previous study, surveillance is less effective for the detection of non-viral HCC. These are changes in tumor size at the diagnosis of HCC between the period from 2000 to 2006, from 2007 to 2030, and from 2040 to 2020. While tumor sizes were getting smaller in viral HCC, it was constant in non-viral HCC during the periods. Also, the percentage of multinodular HCC decreased in viral HCC. It did not differ in non-viral HCC. Consequently, overall survival rates were getting higher in patients with viral HCC. However, they were not increased in patients with non-viral HCC, unfortunately. This may be due to the difference in HCC tumor marker profiles, namely, AFP may be less effective in case of non-viral HCC. Therefore, we compared HCC biomarker profiles between viral and non-viral HCC. In addition, we checked biomarker profiles of SVR HCC that were increasing in recent years. Because tumor marker levels were increasing in association with progression of HCC, we focused on early stage HCC, BCLC class 0 or A in this comparison. Study patients were 2,543 viral and 869 non-viral HCC, excluding recurrent HCC, diagnosed between 2000 and 2020. In addition, 220 HCCs in patients with SVR by DAA, diagnosed between 2040 and 2020, were compared as SVR HCC. All HCCs were BCLC class 0 or A. These are patient backgrounds. Patients with non-viral HCC were more prevalently had habitual alcohol intake and had higher BMI. SVR HCCs were less progressed. This slide shows the serum levels of AFP, AFP-L3, and DCP median with interquartile range at the diagnosis. In comparison to non-viral HCC and SVR HCC, AFP levels of patients with viral HCC were significantly higher. In contrast, DCP levels of patients with non-viral HCC were significantly higher than that of viral HCC and SVR HCC. Consequently, the percentages of patients who showed elevated AFP and DCP above routine cutoff levels differed based on etiology. Whereas AFP elevation was more often observed in viral HCC, DCP elevation was predominant in non-viral HCC with modest elevation of AFP. This may cause less effective surveillance for non-viral HCC. The percentage of patients with AFP-L3 elevation were comparable across etiologies. In patients with SVR HCC, the percentages of patients with elevated tumor markers were lowest regardless of markers. The elevation pattern of tumor markers of HCC may differ, and DCP may be more effective in case of surveillance for non-viral HCC. This will support the superiority of measurements of multiple markers for surveillance. Then, will the combination of these markers make HCC surveillance more effective? In more than 3/4 of HCC, one or more of three biomarkers shows the elevation. This will trigger for the further imaging studies to ultrasonography, potentially increasing the detection of HCC under surveillance. Three tumor markers support each other in surveillance of HCC. In addition, theoretical combination of these markers and patient age and gender may further increase the effectiveness of HCC surveillance. Galad model is a score to identify HCC. This combination score showed superior identification of HCC to respective single biomarker with higher AURC. The effectiveness with a high AURC are regardless of etiology. You can see higher AURC in non-viral HCC. Also, the model was effective for SVR HCC. Serial changes in Galad score and the surveillance were compared. Galad scores were calculated at every visit in 2,273 patients who were undergoing surveillance. Among them, HCC was developed in 130 patients ultimately. In comparison to patients who did not develop HCC, Galad score of patients who developed HCC increased gradually. This increase was observed since around 5 years before the detection of HCC by imaging studies. Therefore, Galad score dynamics can be used as a trigger to consider imaging studies other than ultrasonography. This is a summary. Biomarkers of HCC other than AFP, AFP-L3 and DCP elevated despite normal AFP levels in some HCC patients. So it may be preferable to test multiple biomarkers in the surveillance of HCC. Biomarker profiles of HCC may differ by etiology of HCC, and DCP may be more useful in the surveillance of non-viral HCC. Combination of multiple HCC biomarkers, including Galad model, will increase the effectiveness of the surveillance of HCC. Biomarkers should be more taken into consideration for the effective surveillance of HCC. Finally, I show a new marker that can identify patients with a pre-HCC hepatic nodule. Non-hypervascular hypointense nodules are depicted during hepatobiliary phase of EOB-enhanced MRI and have a high potential to hypervascularize to typical HCC. Our previous study showed that nearly 19% of these nodules ultimately progressed to typical hypervascular HCC. We found that Wisteria floribunda agglutinin positive MAC2 binding protein glycan isomer M2BPZI was associated with the presence of this nodule. M2BPZI was associated with the presence of non-hypervascular hypointense nodules by multivariate analysis and showed the highest AUROC for its presence. M2BPZI can be a biomarker for not HCC but pre-HCC nodules, patients with which should undergo more intensive surveillance. Thank you for your kind attention.
Hello everyone, my name is Judong Yang. Thank you so much for inviting me to talk about clinical impact and cost effectiveness of the HCC surveillance. This is the outline of my talk today. I'll be discussing benefit of the surveillance, harms of the surveillance, and cost effectiveness of the surveillance. Let me start with the benefit of the HCC surveillance. This is the first and the last randomized controlled trial that investigate the impact of the HCC surveillance in patients with the liver disease. This study randomized the patient into surveillance or no surveillance, and they follow through to see whether HCC surveillance decreased the mortality of the liver cancer. So they randomized about close to 10,000 patients into each arms, and over 38,000 years of the follow-up, the 32 patients had the HCC deaths on surveillance arm, and 54 patients died from liver cancer in non-surveillance arm with the mortality rate ratio of 0.63. showing that HCC surveillance decreased the HCC mortality. However, this study should be interpreted with caution, as this study was conducted in China, where the predominant etiology of the HCC were non-cirrhotic chronic hepatitis B. Therefore, it is unclear whether this result will be applicable in patients with cirrhosis, especially considering the nodularity of the liver could impact the surveillance accuracy, and also cirrhotic patient population have higher competing risk of the liver-related mortality. After this randomized controlled trial, no other randomized controlled trial was conducted using ultrasound of the liver as a surveillance test. There was an interesting survey study from Australia where they surveyed the cirrhotic patient population and asked if they are willing to be randomized for surveillance versus no surveillance for HCC. Interestingly, most of the participants declined randomization with the belief that surveillance will likely lead to early stage of cancer detection and therefore the improved survival. So authors concluded that the HCC surveillance RCT would not be ethically feasible. Therefore, there's no randomized controlled trial in cirrhotic patient population for HCC surveillance, and most of the study conducted in the literatures was retrospective cohort study that compare the outcome of patient whose cancer was diagnosed under surveillance versus without surveillance. So this is the landmark paper, a meta-analysis of the 47 study that included 15,000 of the HCC patients by Dr. Singhal, where he showed that HCC surveillance is associated with 2.08-fold increased likelihood of having early stage of HCC and about 2.2-fold increased likelihood of having curative received. What about overall survival? Those whose cancer was diagnosed with under surveillance were more likely to have the prolonged 3-year survival than those whose cancer was diagnosed without surveillance. And also, Dr. Singhal looked at the study that have evaluated and adjusted lead time biases with the surveillance with the lead time ranging between 70 to 239 days. All of this study shows the beneficial impact of the surveillance in improving survival even after adjusting for lead time biases. However, most of the study in the literature compare the outcome of those whose cancer was confirmed and then compare the survival for those whose cancer was detected under surveillance versus no surveillance. However, there's no large study that compare the overall survival of cirrhotic patient population and who who undergo surveillance versus no surveillance. Therefore, we have performed a marker modeling study with the base case of the 50-year-old man with compensated cirrhosis. We model that a patient can die from the progression of the liver disease or die from natural cause, and die from the HCC or HCC treatment. For cirrhotics, can undergo surveillance or no surveillance, and surveillance arm are more likely to have early stage of the HCC, therefore more likely to have potentially curative treatment. So our modeling study shows that HCC surveillance decreased the overall mortality by 5.2% and HCC mortality by 33%. We also performed the one-way sensitivity analysis showing that the liver disease progression and incidence rate of the HCC were most important factor that can affect the impact of the HCC surveillance in decreasing mortality. For those whose liver disease progressed quickly and they have higher risk of the competing risk of the mortality from liver disease, that the benefit of the HCC surveillance decreased. And also those whose incidence of the HCC are high, the benefit of the HCC surveillance increased dramatically. So let's move on to the harms of the HCC surveillance. HCC surveillance first can cause overdiagnosis, which can be defined as a detection of the disease that would not otherwise become clinically apparent during patient lifetime. So these figures on the right explain about the concept of overdiagnosis of the HCC with the surveillance. So without overdiagnosis, cancer can be detected at an asymptomatic phase that a patient receive the potentially curative treatment and have the prolonged survival. However, when overdiagnosis occurs, HCC detection could occur at asymptomatic phase. However, patient die from competing risk of the mortality. For example, a patient with a Child-Fuse C, not a candidate for liver transplantation, was found to have 2 cm single HCC. The detection of the HCC would be overdiagnosis, as that patient died from liver failure, most likely in the next following few months, and HCC diagnosis would not have any impact on patient survival. So why the overdiagnosis occurs? It could be due to inaccurate diagnostic criteria or detection of premalignant or very early malignant lesions, or detection of the indolent tumors, or in the setting of high competing risk of death from liver failure, like I have described with the Child-Fuse C class. So what are the consequences of the overdiagnosis? It can cause the overtreatment and complication, financial and psychological harm. So let's talk a little bit about the physical harms of the HCC surveillance. Physical harm can occur as a result of the HCC surveillance, especially with the indeterminate finding on the ultrasound or alpha-fetoprotein, or a false positive finding that patients are subjected to IV contrast enhanced CT or MRI that can cause radiation exposure or contrast induced toxicity. In a more serious case, patient end up receiving liver biopsy, which can cause significant physical harm. So this study from Dr. Singhal, they analyzed 608 cirrhotic patient population undergoing HCC surveillance program, and they saw that the most of the patient had the ultrasound or alpha-fetoprotein based surveillance, that they saw close to they saw like 119 patient had a physical harm out of the 523 patient who had the surveillance ultrasound. This proportion was lower with the serum alpha-fetoprotein based surveillance, with the physical harm occurs in 73 patients. Most of the harms occur with the false positive or indeterminate result. and concluding that 1 in 4 patients had physical harm from HCC surveillance. There are a few other smaller study that describe the physical harms of the HCC surveillance later on. However, there's no study that describe the psychological and social harms of the HCC surveillance in the literature that should be further investigated in the future study. Let's move on to cost effectiveness of the HCC surveillance. Let me start with the terminology of the cost effectiveness analysis, as this will help you to understand the following study that I'll be showing later on. First, gain life years is the additional number of the years of life a person lives as a result of the receiving treatment, in this case as a result of the HCC surveillance. How many more years they can live is gain life years. Quality adjusted gain life years refers to gain life years, so how many years the patient can live more with surveillance, but after adjusting quality of life index, as a patient with the cirrhosis may not have a full quality of life. Finally, incremental cost-effective ratio, which we call ICER, is the most important and the result in cost-effectiveness analysis, which refers to how much does it cost to have 1 quality adjusted gain life years. For example, with the surveillance, how much does it cost with the ultrasound-based surveillance to have 1 quality adjusted gain life years? Traditionally, if ICER is less than 50,000 US dollars, some intervention or treatment is considered cost effective. This figure on the right demonstrates how to interpret the cost effectiveness analysis. The x-axis is the how effective and in the how effective are the intervention or surveillance is, and y-axis is the how expensive some intervention or surveillance tests are, and this line refers to the different ICER. So if there's some intervention or a surveillance test belong under this line, then something is considered cost effective. So this study from Europe that described the cost effectiveness of the HCC surveillance. So in the study, the average incremental cost for ultrasound-based surveillance in cirrhotic patient population was only $891 with French cost and $11,000 with the US cost. Average ICER is only $3,500 per life year gain in French and $46,000 per life year gain with the US cost. So highlighting that ultrasound-based surveillance for HCC in compensated cirrhotic is highly cost-effective. More recently, MRI has been being considered as a surveillance test for HCC, given the limitation of the ultrasound-based surveillance, although the cost of the MRI is much higher than ultrasound. So several studies have investigated whether the MRI is cost-effective for HCC surveillance. This study by Dr. Young-Suk Lim evaluate the cost-effectiveness of the MRI in comparison to ultrasound in patient with the cirrhosis and chronic hepatitis B, and in patient with the cirrhosis patient population. So when the incidence rate of the HCC is only 1%, either of the MRI-based surveillance versus the ultrasound-based was pretty high at over $100,000. However, if the incidence rate increased to 2%, ISO dropped down to $44,000, which is considered cost-effective. And Dr. Lim also conducted one-way sensitivity analysis demonstrating that the HCC incidence rate is the most important factor determining the cost effectiveness of the HCC surveillance with the MRI, with the ISR of only the $10,000 when incidence rate is 5%. And similar study was conducted in Europe, where they modeled the patient with the cirrhosis undergoing surveillance with the MRI versus the ultrasound of the liver. And as long as you're willing to pay the 50,000 euro, the MRI is 100% cost effective, and so then the ultrasound of the liver. So similarly, they conducted one-way sensitivity analysis to see what are the main determinants of the cost effectiveness of the MRI surveillance. Again, annual incidence rate of the HCC had the most strongest impact on the cost effectiveness of the MRI surveillance when the HCC instance is 10% per year. The ISR was only $5,000 per life year gain. On the other hand, when the annual incidence is 1%, it dramatically increased. However, still less than $50,000. Sorry, actually not US dollar, but euro. Less than 50,000 euro per life year gain, and highlighting that the HCC instance is the most important factors determining the.
Okay, this is clinical course of the case. So at the index visit, he has been receiving ultrasound and serum alpha-fetoprotein as a surveillance test. And his serum alpha-fetoprotein level has been rapidly raised from 3.8 to 129. And at this time, he has received ultrasound surveillance, which was called negative. However, as serum alpha-fetoprotein level was raised too rapidly, he underwent a CT scan right away. And in this CT scan, we found a small nodule with arterial enhancement and delayed washout. To confirm the diagnosis, he has underwent gadolinium enhanced MRI, and there was also arterial enhancement and hepatobiliary phase defect with 2 to high signal with diffusion restrictions. So he has confirmed with a HCC, a very small BCH stage 0 HCC. So other workup result was negative, and he received radiofrequency ablation as a first treatment. He received ultrasound-guided RFA, and after RFA, the serum alpha-fetoprotein level was dropped, but was higher than his baseline. And this is a CT finding of immediate after RFA and 1 month after RFA. But at 3 months after RFA, there was a local tumor progression near the RFA site, which he thought it was a local recurrence. So he received a salvage proton beam therapy at this time. After proton beam therapy, the tumor was well controlled and his alpha-beta protein level was dropped to 2.3 nanogram per milliliter. Thank you for your attention.